Rashmi Halker Singh. I'm the Deputy Editor of Headache. It's my pleasure today to be joined by two colleagues, Dr. Bobby Gibler and Dr. Brooke Reidy, who are authors of a recent publication entitled Preliminary Prospective Observational Investigation of Clinical Outcomes Amongst Treatment-Seeking Youth with Continuous Talcum. So welcome to you both. I'm so excited to talk to you both about this topic. As you may know, I'm a clinician. I see people who have headache all the time, and many of my patients have continuous pain. And this is a topic that comes up. How do we take care of these individuals, as many of our clinical trials don't include these patient populations? So I was really excited to read your paper, and I'm curious to hear from you. What motivated you to do the study?
Sure. Well, thanks for having us. Like you, I definitely have been really passionate about studying youth with continuous headache presentations and understanding what factors influence treatment outcomes so that we can do better by these patients. Our group at Cincinnati has done some retrospective work looking at our clinic-based data and had found that a small percentage made some pretty notable improvements in the initial months after treatment, even though the majority of patients continued to experience continuous head pain. They were reporting improvements in their functioning, severity of headache. And so we're really interested in learning more and wanted to take an initial stab at following some of our patients prospectively and seeing what their initial treatment outcomes were like. And I think this really serves as a foundation for more ongoing work.
Awesome. So tell me about the study. What did you all do and what did you find?
In this study, we followed 28 patients with continuous headache over the course of about 6 to 8 weeks. So they had sort of an initial visit to our multidisciplinary headache center. And then we followed them for 2 visits after that, sort of spaced 6 to 8 weeks apart. And during those visits, participants sort of completed a lot of different questionnaires, and we asked them about their headache presentation. So how many headache days they were having, how severe were their headaches. But we're also psychologists, and so we're really also interested in understanding things like depressive symptoms, anxiety symptoms, psychosocial functioning, and the degree to which headaches are really interfering with their life, so headache-related disability. And we wanted to understand if those factors changed over time, and also what types of treatments these kids were using over time. We were really interested in understanding that as well. And so this was a prospective longitudinal observational study. We didn't do any intervention. We just followed them for those 3 different time points. And we just kind of descriptively characterized those factors. So looking at headache characteristics, anxiety and depressive symptoms, and disability and treatment utilization.
So what did you all find? Were you surprised by anything?
I think we were surprised by a lot of things. I think the findings of the study were really interesting, actually consistent with some of the research that Dr. Reidy was describing earlier. We did see that a considerable portion of the participants, I think almost 50%, reported a break in their headache by that 3rd time point, which is really exciting because it suggests that, when kids are sort of getting this multidisciplinary, biopsychosocially oriented care, that they do see a pretty rapid treatment response. We did see that the majority of participants reported severe headache-related disability even at that 3rd time point, but the percentage of participants who were saying that they had little to no disability increased from about 4% at the initial visit to 20% at the 3rd visit. So really, again, suggesting that there are these improvements happening. In terms of anxiety and depressive symptoms, we found that those were pretty stable across all time points. So we didn't necessarily see that these patients were sort of more psychosocially distressed, than we might expect in a patient population presenting with chronic migraine to our center. So they weren't necessarily more distressed. Um, I think the one of the most interesting findings is that we saw that kind of the most consistent treatments that were used were, acute medicines like ibuprofen, acetaminophen, and consistent with sort of what the initial treatment recommendation would be. We saw rates of prescription preventive medications increasing from time 1 to time 3. But as psychologists, what we were really surprised by is that the endorsed use of non-pharmacological interventions decreased from that first time point to that third time point. So participants who were reporting that they were doing things like, relaxation exercises or participating in cognitive behavioral therapy, that kind of decreased over time. And there could be a lot of reasons why that might be, but I think those were kind of the most striking findings to us. Dr. Reed, did I miss anything important?
No, I think you hit all the main points. I do think it was interesting for me that we did sort of replicate some of the general patterns that we were seeing in our retrospective sample. So I think that was what I was kind of interested to see, is if that would hold in a prospective fashion, and it did. But yeah, I'm really interested in seeing moving forward in larger samples what treatment utilization patterns look like and how that might be related to outcomes over time. Since this was a pilot, we couldn't really look at that, but it was interesting that I was expecting the uptick in preventive medications, but the decrease in the non-pharmacological treatments was something notable, I think.
I think even though this was a small study, I was really excited to read it. It gave me, I guess I'll put it this way, it gave me hope to share with my patients. I have so many patients that come in with daily pain, including adolescents, because we do see adolescents in our clinic. And you always, or I'll use I sentences. I always want to be able to talk to patients about things that would be inclusive of them, and like studies that are representative of their experience. And it's sometimes hard to find that because we don't always include people who have continuous pain in clinical trials. So, daily pain is often an exclusion criteria. So we can say, try this medication. We hope it helps you. But unfortunately, daily pain was not included in the trial, but we're going to cross our fingers. And so this study gave me a little bit of hope to share with my patients, despite the fact that it was a small trial, it was a pilot study, because as you both shared, many of them did well, and there were opportunities to see benefit and some hope. And I was able to, I'd be able to share that with my patients about the fact that they did not do worse, or they had different types of functional improvements. And I thought that was exciting.
Oh, good. I do too. And I think also just clinically, you know, I think we remember a lot of the patients that have a really protracted course and they are really taking a long time to get better. And it is hopeful that there is a subset of our patients that show some improvement in the initial, 3 to 4 months of treatment. So that's really exciting, I think.
Any other reflections that you both had as, the ones who did the work?
I'm just excited to continue to study this group more. I think that continuous headache as a phenomenon is still something that we want to learn a lot more about, especially in the context of headache disorders. And so I'm really interested in doing more work and trying to include this patient population in more research, because I think that there's a lot we can do to learn about them and support their treatment.
Well,
was just going to say I echo that, and I think there's a lot of work to do, especially in the non-pharmacological intervention space. We have a lot of work to do in terms of understanding what these patients' preferences are for treatment, and what we might be able to do to, improve sort of the evidence-based recommendations that we already provide. How can we really optimize these treatments for kids with continuous headaches? So I think I also feel hopeful that this is a exciting area for future research, and that the future is bright.
Awesome. Well, thank you both for speaking with me today, and I look forward to more work from both of you.
Wonderful. It was great talking with you.
Thanks so much for your time.